Muchas gracias. I'm sorry that I don't speak Spanish. Back 25 years ago when we moved to the United States on our Persian rug from Iran, I used to listen to my parents and they asked that I take French. So I apologize because all of us are now punished. So I'm going to talk about constipation. These are my disclosures. Our objective is to discuss the most up-to-date approach for the diagnosis of constipation, to discuss some of the treatment options that are beyond the conventional treatments that we may already know about, and to talk about biofeedback therapy, which is a common therapy we use for treating patients who have defecatory disorders. To start off, I want to present a case. This is a 32-year-old female who came into our clinic. She was complaining that she's only having one bowel movement a week. This is changed from her baseline. Previously, she's had hard, pellet-like stools. She strains when she has bowel movements. She has incomplete defecation and is also complaining of urinary urgency. Her past history is just C-section that she's had twice. Her treatments have included a bunch of different over-the-counter laxatives, stimulants, stool softeners, and then fiber supplementation that had been recommended by her gastroenterologist. So how would we go about investigating this patient further? So chronic constipation is very common. In the United States, the prevalence is about 16%, and 34% of adults aged 60 to 101 have constipation. It's higher in non-whites and women, with the risk being 1.5 to 1. And in the United States, there's 8 million cases, and it exceeds 230 million. Interestingly, between 1993 and 96, comparing that to 2000, 2004, the use of osmotic laxatives has actually increased, bulking agents has actually decreased, and our stimulant use has not changed. So how do we define chronic constipation? This is actually based on the Rome 3 criteria for chronic constipation. With IBS with constipation, that has a different diagnostic criteria. However, people could say that these are really spectrum diseases, with IBS with constipation being on one side of the spectrum, where patients have mostly abdominal pain associated with the change in their bowel habits, and patients who have chronic constipation not really having that much abdominal pain. However, patients who are very constipated will complain of pain at times. So these are kind of arbitrary, and they're based on expert decisions. So chronic constipation is defined as symptoms more than 6 months, and at least two of these symptoms 25% of the time during defecations in the past 3 months. Straining, lumpy, hard stools, sensation of incomplete evacuation, some kind of anorectal obstruction. If the patients had loose stools, that's an exclusion. Manual maneuvers in less than 3 of their defecations. And I won't go through IBS because that's not the purpose of this lecture. The alarm features, these are reasons, red flags, and reasons for us to do a colonoscopy on these patients. So if there's a symptom onset after age 50, anyone 50 and up should have a colonoscopy for screening. An abrupt onset and change in bowel habits, weight loss over 10 pounds, family history of colon cancer, abdominal or rectal mass are all reasons to do a colonoscopy first. So in this patient, how do we diagnose her further? Classification of primary constipation, this is based on the recent AGA technical review that was published in this year. And they have subgrouped patients, not looking at functional constipation, which is what the Rome criteria is based on, but subgrouping patients based on actual diagnostic studies. So based on that, we group patients into normal transit constipation, slow transit constipation, and then those patients who have a sort of a defecatory disorder. These are the diagnostic tests for lower GI problems that we have available, including constipation. Colonoscopy, again, we discussed that only if patients have an alarm symptom that should be performed. Transit study, we have whole gut scintigraphy. Not a lot of institutions have that available. It's very costly, and we don't have that at University of Miami, for example. It's hard enough to get them to standardized gastric emptying scintigraphy. SITS marker study can be very valuable. That's a transit study. We'll talk about the wireless motility capsule, the smart pill. And then there's manometry, anorectal. Colonic manometry is also not widely available. Very few motility centers have that. And then balloon expulsion study. MRI defecography has not been standardized either, but it's gaining favor. So we'll talk about all of those. The rectal examination can be really important to rule out some kind of obstructive defecation. Obviously, if a patient has a mass, you can feel it on exam. Compared to an anorectal manometry, the sensitivity of this test is about 75%, and the specificity is 87%. So the rectal examination, where you're actually feeling the sphincter tone, feeling for the puborectalis muscle, and seeing if the patient on Valsalva is able to relax that muscle, can be very important, other than fissures, hemorrhoids, etc. So this was modified from the study that was done by Remus Troche, and this is looking at all of the utility of the different diagnostic studies that we have available. Thyroid function studies, calcium, we often check to rule out metabolic disorders, but the recommendation is grade C. Barium enema, colonoscopy, same, unless there's alarm symptoms, of course. With colonic transit studies, that actually has higher favor. So it's a B2 recommendation, with wireless motility capsule getting an A grade on that. And then anorectal manometry, balloon expulsion also are favored as far as diagnostic studies for chronic constipation. This is showing scintigraphy. Again, we talked about whole gut scintigraphy. It's done in very few centers. They use indium, and that's what they label the meal. And then you can document what parts of the colon, etc., the meal is in. But this is very labor intensive, and very few places have this available. The wireless motility capsule, it's a capsule, so it's different than the capsule endoscopy in that this actually obtains manometric pressure readings, as well as the changes in pH that tell us what part of the GI tract we're actually in. So this is FDA approved in the United States for gastroparesis, as well as slow transit constipation. Most often, I use this study if the patient has upper GI problems as well as lower GI symptoms, and I'm not able to differentiate which one's worse and which one I should treat first. So oftentimes, patients will have overlap of symptoms. The nice thing about this study is that there's no radiation exposure. It actually is less expensive than scintigraphy, and it can be helpful to the patient since it's ambulatory. This is the whole study shown here. So the pH, which is the green line, that changes in the pH will tell us what part of the GI tract we're in. So a low pH tells us here we're in the stomach. As the pH goes up by about 2 units, we know that we're now in the small bowel. And as it goes through, this is the IC valve. As it goes through the IC valve, the colonic bacteria will actually ferment, and they cause the pH to drop at least by 1 point. So you know here, you're now starting to be in the colon, and then this entire part is in the colon. So you can actually calculate how long this capsule was in the colon, how long in the small bowel, and then how long it was in the stomach. These are the pressure readings that can be obtained. This has not been validated yet as far as the motility index pre and postprandial. So at this point in time, motility experts use this. However, again, it has not been validated. And then this is the temperature reading, the blue line up here, where a drop just tells you when the capsule has exited the body. The traditional colonic transit studies, this is the SITS marker study that's very inexpensive, can be done to evaluate for slow transit constipation as well. And this is done with different ways. One way is with a capsule that the patient will swallow, and 5 days later, an X-ray is obtained. So in this setting, the markers are retained in the colon, and they're throughout the colon. So this is a patient that has colonic inertia. Maybe they have colonic dysmotility, decreased interstitial cells of Cajal, etc. In this patient, this is 5 days after they ingested the capsule. There's many markers that are actually in the rectum. You can see them in the sigmoid, left part of the colon, and that's a patient that may have obstructive defecation. And this study by Satish Rao compared, this is how they validated the wireless motility capsule for slow transit constipation, and here they compared the wireless motility capsule to the traditional SITS marker study, and based on this, the correlation ratio is about 0.7, so they do correlate. And then there's anorectal manometry. So this is a very useful study. Again, it was a B2 recommendation for evaluating patient with defecatory disorders. There's not many cases of Hirschsprung's disease in the adult population, but you can evaluate what the rectal anal inhibitory reflex is in patients, and perhaps they have other causes of no rare. And again, this is a balloon that's placed in the rectum, and it has sensors that tell us what the pressure readings and the sphincters are. We ask the patient to push. We evaluate this at rest with the patient squeezing, and then we do push maneuvers. And we see if the patient can sense the balloon, if they feel a sense of urgency, and if they adequately relax the muscles as they're defecating. This is a manometry on one of our patients. So this is there is a traditional way of doing this with station pull-through that can be more difficult for the nurses to perform. This is with the new high-resolution manometry equipment that many centers now have. So here to here, we have the sphincter, and this is the sphincter muscle at rest. And this is color topography, so the lower pressure readings are down here, and then as you go up and it gets more red, those are higher pressure readings. So if you have a patient who has anismus, you can actually see that on the manometry during rest. So this is a normal patient, normal rest pressure. It has 3D capabilities if you buy that extra equipment. And so this is the sphincter muscle right there, and the anterior line, this is close to the vagina, can be determined by this white line. So you can see if a patient, for example, with fecal incontinence has a defect, you may not see a contraction at that one point. And so this is rest pressure here. This is the sphincter again. And then here we have the squeeze. So after patient squeezes, there's an increase, appropriate increase in the pressure as the external sphincter contract and as the puborectalis muscle contracts. So this is very easy for teaching the fellows, and it's pretty. So on bear down, this is what a bear down should look like. So this is the sphincter here, and as the patient pushes, there is a relaxation of the sphincter, which is appropriate, and then it contracts back up. So we look for that relaxation. And then there's balloon expulsion studies. This is very informative for patients with defecatory disorders. You put a balloon into the rectum. We distend it to about 50 cc's. We can increase it incrementally. For example, if the patient is not able to sense 50 cc's, the patient sits in a commode, and then we ask them to expel the balloon. It can be difficult if you're in the room at the same time, so you want to make sure you give the patient privacy. And then you see if less than 1 to 5 minutes, depending on what your center uses, but usually I give them 5 minutes to expel the balloon. If they're able to do that, then it's less likely that they have some sort of obstructive defecation. And compared to defecography, the sensitivity is 87%, specificity is 89%. So it's very easy and useful, and this would be a very cheap thing to do in an office setting. MRI defecography, the images are beautiful. It can show us the structures of the bladder. It can show us if there's intussusception, if there's prolapse. This patient, for example, has an anterior rectal seal. A contrast is placed in the rectum as well as the bladder. And as the patient, again, pushes in a left lateral decubitus position, which is difficult, we see if there's a rectal seal. So this patient, for example, has an anterior rectal seal. This patient has abnormal perineal descent, so they are not able to actually defecate. So this could be from many years of straining where they've weakened their pelvic floor. You can actually cause pudendal neuropathy by doing that. And so this is a nice way of seeing the whole structures in unison, all the anatomy. So what treatments can we offer our patient? There are adjunctive approaches. We can tell the patient to increase fluid intake. We often say that. As when we see our patients, but studies have been done. It shows no benefit unless the patient's actually dehydrated. Physical activity can definitely improve gas clearance and bloating, and this has been shown. Fiber supplementation, we often also tell patients, so I'll show you, psyllium, other soluble fibers can be beneficial, and then probiotics for chronic constipation, there's limited data, actually more data with irritable bowel syndrome than this. So when we compare our conventional over-the-counter agents with the newer therapies for chronic constipation, this is also adapted from the AGA technical review. So they looked at well-designed studies, with randomized placebo-controlled studies, This is the number needed to treat, the number of patients in each study, and the quality of the evidence. So actually, the quality of the evidence with our traditional treatments, osmotics, stimulants, and PEG, are actually high. The number needed to treat is much better, actually, than the newer agents. The newer agents, we'll talk about lubiprostone, linaclotide, and prucalopride. These are available in the US and Europe as well. And there's moderate quality of evidence. And some of the reason for that is that the outcome measures that the NIH has put on, these companies, pharmaceutical companies, is actually much harder than the initial studies that were done. So it depends on what the outcome measures are, and you can't really compare one study to the other. It's the same with studies that have been done in irritable bowel syndrome. And this is looking at, again, chronic constipation and not irritable bowel syndrome, where there's also a component of abdominal pain. And so perhaps these other medications could be more important for those patients and more useful. So the newer treatments, we have lubiprostone that stimulates chloride apical secretion on the chloride channel. These are apical chloride channels. It accelerates small bowel and colonic transit. And there's phase 2 and phase 3 that have been completed for both chronic constipation and IBS. We have linaclotide that also stimulates chloride secretion. It activates the cystic fibrosis transmembrane regulator, and that accelerates colonic transit in IBS-C and also in chronic constipation. Linaclotide also inhibits the afferent nerve fiber from firing, so it can also help pain. Prucalopride works on the 5-HT4, it's a 5-HT4 agonist, and it accelerates colonic transit in both health and also chronic constipation. We don't have this available in the US yet, as the FDA has not approved it, and there are no studies in irritable bowel syndrome as of yet. So this is looking at lubiprostone in IBS-C and chronic constipation as compared to placebo, and they looked at the response rate. This is the response rates 2 out of 3 months if they had improvement. And there was 17% improvement on lubiprostone versus 10% on placebo. It is pregnancy category C, and there is a dose-dependent increase in nausea, so with the 24 microgram dose. The 24 microgram dose is what's recommended for chronic constipation, and for IBS is the 8 microgram dose. Then there's linaclotide, which is a guanylate cyclase C agonist, and this helps with both the abdominal discomfort, constipation, and then the overall relief and global symptoms. And this is also available now in the US. And then we have prucalopride for chronic constipation. In this study, this was a 12-week trial. They compared placebo, 2 milligrams of prucalopride, with 4 milligrams of prucalopride, and they looked at the number of patients who had more than 3 complete spontaneous bowel movements. And there was an improvement with both the doses for chronic constipation. So now what do we do with our patient? What did we do? We did a SITS marker study, and she had over 20% of the markers in the left colon and rectum, so it wasn't spread throughout. This is on day 5. We did a wireless motility capsule on her because she also had later upper GI symptoms, started having early satiety, nausea, and I wanted to make sure she doesn't also have gastroparesis, although if you take a patient who has severe constipation, they often will have upper GI symptoms as well. So her gastric motility was normal. This is when it goes through the IC valve, and from here to there is the colonic transit, and you can measure that. So on her, it was 82 hours, with less than 59 hours in the colon being a normal study. So she did have slow transit, right? Or perhaps this was due to the obstructive defecation, because on the SITS marker study, all of the markers were on the left side. So probably the most useful test on her is the anorectal manometry. And what we did is, this is during rest. So she has anismus. She had very high rest pressures in the sphincters. It was over 90. Anything over 90 is high during rest. Then this is during the bear down maneuver. So this is asking her to push, and she actually is contracting the muscles rather than pushing. This is the rectal balloon, so it shows that she is using her abdominal muscles, but that's not able to overcome the pressure in the rectal sphincters, which she's squeezing, and the puborectalis. So what she has is this synergic defecation as the cause of her constipation. We did find that on the SITS marker as well. The markers were on the left side of the colon. We treated her with lubiprostone, 24 micrograms twice a day, and then the treatment of choice for that patient would be biofeedback therapy. So just to quickly go over this, what is biofeedback? This is a Times magazine from 1995 where Schwartz talked about biofeedback, and this is a way that we use electronic instruments to visually feedback to the patient what they're actually doing on a monitor that they're able to see. There's auditory and visual stimuli. The indications are many urologists are very familiar with this. They use it for interstitial cystitis, urinary incontinence. We can use it for fecal incontinence, pelvic pain, prolapse, pre-surgery, and also for chronic constipation if there's a non-relaxing puber rectalis. The process, there's electrodes that are placed at the rectal area. Instruments process this, and then this visually patient is able to see what they're contracting as they're doing it. There is a behavioral component, so we ask patients to keep a diary. That's helpful for both the clinician and also for the physician, because you can see, are they not going to the restroom when they need to? Are they suppressing their urge? And, do they have timed voiding? And on EMG, this is what should happen. The abdominal muscles contract, and the external sphincter muscles should relax. And then this is a biofeedback on one of our patients at this patient, this is the levator-ani muscle. This is the abdominal muscles. And here, this is a normal patient who doesn't have defecatory dysfunction, and they're able to, during push, to relax the levator-ani muscle. This is a patient that has this synergic defecation, and they actually contract the muscle rather than relax it. So we can measure that in millivolts, and anything over 2 and up is abnormal. Comparing to laxatives as a therapy for constipation, this is a very well-designed study by Bill Whitehead, and they looked at 12 months of patients on either biofeedback or laxatives and looked at the number of incomplete bowel movements. And if the patient received biofeedback therapy, and this is 1-hour sessions of 6 cycles, they had a more significant improvement in their constipation than if the patient just received laxatives as treatment. So just to summarize, the AGA and the Rome-3 now emphasize the need to identify defecatory disorders in treating patients with chronic constipation. 23% of patients who are diagnosed as normal transit constipation and slow transit actually also have defecatory disorders. Using anorectal manometry and balloon expulsion can be very helpful. The SITS marker study or wireless motility capsule can also be complementary if you have patients who on conventional medical treatments are not improving. And another point is that the traditional over-the-counter agents for chronic constipation are actually very safe, they're effective, and they're very inexpensive. We oftentimes now with insurances have a lot of trouble getting these patients the other drugs. And we often have to call the insurance companies, and we have to prove that they've gone through these over-the-counter medicines before we can start those. But at least now we have an AGA guideline that shows us that they're just as effective for chronic constipation as our other more expensive therapies. Thank you.